All right, everybody, welcome back to another episode of the Sports Medicine Project. Now, it's just me today without my partner. Kelly has a patient, and I know she's fuming she couldn't get to be on this episode because we're here with Dr. Ahmad Malik. Now, he is over in the UK at the moment, and you guys know by seeing our Instagram and our previous podcast, we've been teasing this guest coming on for a while. So I'm super excited to get this episode out. So he is an orthopedic surgeon working at the Princess Grace Hospital and the London Foot and Ankle Clinic, which I hope and I haven't butchered. But I'm going to hand it straight over to him and basically give us a bit of an introduction and what he's all about. So yes, welcome on the podcast.
Thanks, Blake. As you can see, it's sunny over here in the UK, and actually looks sunnier here than where you are.
Yeah, it's not looking too good in my little basement of a room or my office.
Yeah. So no, thanks for inviting me. So what am I all about? I'm an orthopedic surgeon. I was born in Glasgow, up in Scotland. It's very grey and wet there. And this is a long time ago, 1975. I think I always wanted to be a doctor. I was very fascinated by the healthcare system and dissecting frogs and biology lessons and stuff like that. It was just I just found the whole thing just fascinating. Yeah. There was a small time when I wanted to be a Top Gun fighter pilot after watching Top Gun, but
how the new one's just about to come out. I'm so excited. I've booked that in next week, 25th of May. I can't wait.
Yeah, so yeah, definitely wanted to be Maverick. But then my mum said, well, what are you going to do afterwards? Be a bus driver up in the skies. And that put me off. So anyway, I became a doctor, studied up in Glasgow, came down to London for 6 months, and the rest is history. I just got sucked in by the vortex of big city life. Yeah. But whenever I made plans in life, it never really worked out. I wanted to be a general surgeon. I ended up being an orthopedic surgeon. I wanted to be a hip surgeon, then I ended up being a foot and ankle surgeon. I wanted to work in a central city teaching university hospital, environment. I ended up working out in the sticks. So anyway, that's been my life. Whenever I made plans, God just laughed and thought, whatever.
Said you're not doing this, you're doing what we think.
Yeah. And then 4 or 5 years ago, my dad was dying of cancer, and I had this epiphany, and I was like, why am I working like I am? So I left the NHS and went private to have a better quality of life, to work as long and as hard, and also working privately gives me the opportunity to treat patients the way I'd want to treat my family. Treating 40 patients in an afternoon clinic where everyone is just a number and like you're in and out of a room, I found that very stressful. That's not the kind of healthcare.
It's interesting, and I mean it's a common, I guess, complaint that we hear kind of in the allied health world, sometimes that you just feel like a number because you're in and out. And when you're seeing that many patients, I guess you've got no choice in your spot. What's the pathway? Because I'm sure it's different in the UK and Australia. What's the pathway of coming from medical school to orthopedic foot and ankle? Because you've got to go through a whole amount, don't you?
Oh, yeah.
It's not just a pull it out of the cereal box kind of thing.
No, so you work like crazy in high school to get the grades, to get into university. Then you do 5 to 6, 7 years of university, depending if you do an additional degree or not. So you come out of med school 22, 23, 24. I came out at 22. Then you do a few years of junior medical training, then junior surgical training, then higher surgical training, and that's 2 years, 3 years, 5 years. And then fellowship, which is 1 or 2 years, and then you bide your time looking for a consultant job. So I was cooked and ready to go as a consultant at the age of 36.
Yeah, wow.
And I went into med school at 18.
Yeah, wow.
So half my life up until that point was just getting to
Yeah, and you loved every minute of it, I'm sure. Somewhat. You can't see it's audio, but there's an eye roll there.
I mean, it's not easy. There's a lot of sacrifices. Yeah. I look back and it was a gruel. It was a grind. It was tough. Tough.
Is a consultant? So over here, it seemed like you obviously go through your training and then you work privately. It tends to be the trend foot and ankle surgeons over here do a little bit of work in the public system and then predominantly a lot of their work in the private. So as a consultant, if you've got a private practice surgery where you're doing surgeries, that's what's a consultant. That's what you are. Is that right?
Yeah. So over here it's different. You probably don't know this, but I did a fellowship in Sydney, so I know how the system works.
Wow. 2 hours. Yeah. Okay. Newcastle's 2 hours north. So very nice.
Yeah, I know. You guys are a little bit more grounded and down to earth.
Yeah. Chilled out, intelligent,
You're
better
more
looking.
chilled out. Yeah. Chiseled jaw. No, so basically, yeah, I know how the system works over there. Over here, I would say most doctors do 90% of their work in the NHS. And if you're in an affluent area, then you do a little bit more private practice.
Yeah.
But very few people go out and do, just full-time private. I think for a lot of people, they just feel like there's no safety net. It's a big leap. You're almost conditioned to be in the system. I'm not going to say it's a cult, but the NHS is, it just holds on to you. But there's a lot of good things about the NHS, but there's a lot of bad things about the NHS.
Yeah.
I can say this being on the outside, and some people say, well, you would say that as conflict of interest, but I mean, I was head of the department for 3 years, and I was trying to do a lot of change and try and improve things, and that was the real wake-up call. I just realized I had all this responsibility and no power. I just learned helplessness. And the system is great for emergency healthcare. If you're in a car accident, it'll scoop you off the tarmac and sort you out. But then as soon as you go home, that's where everything goes pear-shaped. It's just bureaucracy and inefficiency and mistakes, and it's just the system is just very broken.
And it would be so hard to change, wouldn't it? Because it's huge. I mean, obviously it would be top down, but like it would just take forever to implement that kind of change.
Take forever. And I'm not saying, it's funny, so I'm a full-time doctor and I really do believe in the NHS, but it needs radical change. The thing is, it rewards you for being mediocre, not really excelling, not working hard. It's very difficult to get sacked. You've got a job for life. And the more efficient and hardworking you are, you just get dumped more work on top of it. No one thanks you. There's no, there's no incentive to be hardworking. You don't get rewarded for being more efficient. So, I mean, that's, I think, one of the main problems with the NHS. And if they can just crack that, then it would be so much better. But, people will drag their feet and do the bare minimum, if that makes sense.
Yeah. Yeah. So what's your setup at the moment? Do you like a couple of days consulting and then a couple of days surgery?
No, it's more consulting. So we should let your viewers, listeners know, you sent me some questions and you're talking about conversion rates and what people think surgeons are like. I think like most of my peers, most of the foot and ankle surgeons I know will say that their conversion rate is around about 15 to 20%. So if your listeners don't know what that means, it means like, say, for example, 100 patients come and see me. Out of those 100 patients, 20% will end up having surgery. And I would say that's pretty much like an average, amongst ankle surgeons. I think when it comes to private surgeons, foot and ankle surgeons, I'd say it's even lower. Amongst my private full-time colleagues, I've heard figures of 10 to 20%. Wow.
Which is incredibly low. Like that's really low. Like out of 100 patients, only 10, that's I
think my conversion rate is 5%.
Yeah. So, wow. Because we were just talking like offline before about, for younger clinicians, their kind of perception of surgery is, it's not even worth a consult or an opinion or sending a patient that you're struggling with to see you guys because they'll just end up with surgery and something will go wrong. But with conversion rates,
for sure, there are some bad apples out there, for sure. Okay, where someone is just either, they don't have any other tool in their toolbox, and they just, and I'm not saying there's some ulterior motive that financial, right? I'm going to make money out of this operation. Well, they just simply don't have any other thing they can think of other than you need an operation. For sure, there's some bad apples like that. But then I'll say it's like that in every walk of life.
Every profession.
there's podiatrists I know who, you know, if you say you've got jaw pain, they'll be like, oh, you need an orthotics.
But you're going to be receiving some death threats in the mail after that. But we always talk about that on the podcast.
I'm just thinking you can say this for everything.
Yes, yeah.
You know, there'll be physios out there. I know, because my patients come and see me. You go, oh yeah, I was told I need 50 sessions of physio.
Yeah, 4 times a week. Yeah.
But it's not just us,
Yeah.
it's everybody. You know, I'm trying to get some patio slabs laid down, and there's some wild cowboys, you know, they're trying to take me for a ride. It's any walk of life. There's some bad apples out there, but generally speaking, most people are good eggs trying to do a good job, you know. And I think the problem is the bad apples taint a bad image of whatever profession it is, and you think they're all like that. Not really. Now, I think the reason why the conversion rate is slightly lower in the private sector is twofold. One, in the NHS, a lot of these patients have gone through a local MSK pathway where they've been selected, sent for physio, sent for podiatry, and you know, they are just desperately in need of some form of surgery. So the kind of patient that the NHS consultant is seeing is one that's going to lend to a higher conversion, because they've jumped through all the
that makes sense.
Okay, so they've been hovering around the airport, flying on vapors, and they just need to land, right? They don't need any more non-operative treatment. They just need treatment. So their conversion rates can be a little bit higher.
Yeah.
And in the private sector, you've got a lot of people who are very health conscious, very fit, and they've got access to healthcare, and they're picking up early. Oh, I've got this pain. I've had it for 4 weeks. And because you're getting there early, they don't need surgery. What they need is guidance. They need advice. They need other therapies.
Reassurance, that kind of thing.
Reassurance, that kind of thing. And then finally, the other thing as well is I am very picky about who I operate. Now, I mean, technically, honestly, half the patients that come through my door, I could do something. You know, I mean, these are not crazy patients coming to see me and spend money, you know, for no reason. There's something troubling them. But then I want to make sure that, one, I can trust that patient. 2, I can rest, you know, comfortably at night, like a baby, sleep like a baby, knowing that I've tried everything to avoid an operation. And then thirdly, there's some people who aren't helping themselves. So why am I going to help them? You know, their expectation is, the kind of person is like, I've got high blood pressure, give me a tablet. Or, I'm feeling down, give me a tablet. Or, I've got pain, give me an injection. Or, you know what, my foot's not working, give me an operation. You do everything, you fix it. I don't want to take any responsibility. I don't want that kind of patient.
And you find you don't get that kind of patient, because we talk about it on the podcast and on our Instagram, like the biopsychosocial approach to pain and things like that. You know, and I'll just use an example, like low socioeconomic, doesn't really want to engage with health, not a great health literacy. It's, I've got osteoarthritis, or, I need fixing. Do you find that you don't get that kind of patient as much privately? They're more in the NHS system, or is that?
That's a really good question. I would, while it's easy to kind of say, oh yeah, low socioeconomic class, I don't think so. I mean, some of the, maybe it's because I'm from a working class background, mate. You need to stand up for them. They're really stoic. They can't afford to have time off. They need to work. They're working, week by week, paycheck by paycheck. And, those kind of patients actually, if anything, kind of neglect a problem. They're like, fucking,
they cope up.
I'll just cope with it. Sometimes it's actually the more affluent people who, too posh to push kind of people who maybe Sydney North suburb type people, just like, and I've got this problem, fix it. They don't want to put in hard graft. I mean, what I'm trying to say is, you give one stereotype, I could throw it back other stereotypes. I think it's just generalized. You can't generalize. People are people. There's some people who are very motivated, and there's some people who aren't. There's some people who've got realistic expectations, and there's some people who aren't. And my one advice to all your listeners is that, to be a good clinician of any sort, you don't have to be just good at what you do. You need to be good at being a people person. You need to read people. You need to almost be like a psychiatrist or psychologist. Read people, read their backgrounds, see where they're coming from. What other issues are there? Those anxious people that you want to just label as crazy, wearing the tinted glasses. there's always some other baggage, some other shit in the background. You know what? And I take my time just like digging and poking and scratching, and suddenly, boom, this avalanche.
It just comes out. Yeah.
Yeah, and you're like, oh shit, thank God I didn't rush into an operation on this one, because you know what? They're going to have the poor outcome. You know? And while surgery might be indicated, you need to also think about who are the winners and who are not going to be the winners. And if they're not going to be winners, what are the issues that you can deal with or help them with? And sometimes, I end up feeling like I'm giving them, work advice or stress advice or nutritional advice or sleep advice or stress management advice. But that's where, I'm a doctor. I'm a doctor first, and then I'm a surgeon, and then I'm a foot and ankle specialist. And, I think I've got good outcomes because I work like that. I don't have this tunnel vision. Oh, yeah, that needs an operation.
Yeah. It's funny that you mentioned that, and it's incredibly insightful to see. And that's why we, wanted to do this podcast, is to show, the students as well as people in their first 10 years that it's not all, I guess, the biomechanical, treating people like a car. This needs fixing now, and understanding that there's so many other psychosocial factors. So it's incredible to hear. I just finished a day teaching at the university, and I was talking to the students, about us recording this tonight. And one of the younger students, she was in her second year, asked me a really, really good question that I wanted to ask you before we get into this. Is a consult for you, or an initial consult, because we were talking about, because they've got their exams coming up, how we go from, subjective to objective to assessment to treatment and so forth. What does an initial consult look like for you? Let's say something generic that's common. I think it's common, like an adult acquired flat foot. Would that be something commonly you see? Yeah. So if someone referred to you, they've tried orthotics, they've tried strength and conditioning, footwear, everything. How does that kind of go? And obviously it's hard to say because it's individual, but
So just to put it into context, I'm almost 47. Okay, I'm going to be 47 in July.
Right, you don't look a day over 25. I'll give you that.
You
can't see it on the audio, guys, but he's young.
So basically, it's been a journey. I've been a doctor since 22. So what is that? Wow, 25 years.
It's a long time.
Fuck.
Yeah, I'm 26. So you've barely been a doctor more than a year, and I'm a year younger. Crazy.
I could be your dad. Just just think about that. Think about that, right? So so what I want to say is, like, it's constantly evolving. My consultation this year is different from what I was doing last year. Because as I grow and develop and appreciate different things, I'm learning to finesse. It's a constant. You're constantly improving what you're doing, and I hope most people are doing that. I like to push myself. I always want to better myself. I always want to learn new things. And you were taught in med school, take history, and the history is presenting complaint, symptoms, past medical history, drug history, social history, then examination, blah blah blah. It's kind of evolving now for me. It's really evolving. So let's say, how do I start off my history? So first of all, I go, hi. And Ahmed, thanks for coming to see me, blah, blah, blah. So what brings you here? What is the issue? What can I help you with? And I just let them talk. And I don't try not to interrupt and listen to them. A lot of people just want to get things off their chest. And the art as a clinician is sifting through the gumph and holding on to what's important. And the moment someone starts saying, oh, and I saw this person and they said, I go, no. I don't want to hear another diagnosis. I don't want to hear medical terminology. Do not introduce bias. You want my opinion, not someone else's. And then try and get details, because quite often people just jump through things. So for example, I had someone yesterday who went, I tripped 6 weeks ago, and then it's not got better. It got better, but then it didn't get better. And I thought I should come and see you. And my physio thought I should see you. Okay, and that was the opening line. And I was like, whoa, let's roll right back. When you say trip, what actually happened? And were you able to weight bear? Was there any swelling? Where was the swelling? Where was the bruising? Oh, inside and outside ankle. How soon were you able to walk comfortably? Okay, 2 weeks. When you say it was like almost normal. What did that actually mean? What do you mean by that? And then, so then I try and then some of them, go, oh, wow, there's a lot of questions. I'm like, look, it's not an interrogation. The reality is you're a blank canvas. And some people will volunteer lots of pain and fill in all the gaps, and or the jigsaw puzzle, and give me lots of pieces to play with. Other people, it's very difficult, and I have to extract that. Because the truth is, Blake, 95% of the time, just a good history from a patient will tell me the diagnosis.
Yes, I said this to a student today that was talking about some forefoot stuff, and she thought it was a stress fracture and an old lady that doesn't do too much. But I said, with a good history, you can rule that out for sure. So that's great to hear.
Yeah, and then for example, or a runner, So yeah, I just want to let you know I'm a runner and I run a lot. So I start getting foot pain. I'm like, whoa, stop. How long have you been running for? What do your runs look like? What's the distance and duration? What's the frequency? What's your targets? Is it pace? Is it speed? Or are you recreational? Is it off
so good to hear.
Then, do you do any other form of exercise? And oh God, 90% of runners are like, yeah, I run. And then what else do you do? Oh, I do like 2 short runs a week and then 1 long run a week. Any other kind of, sometimes I do interval training. Often it's row, sometimes I do cross country. I'm like, any other, well, I mean, that's a lot. I'm like, well, what you've described so far in terms of a healthy diet is you eat an apple every day, and apples are healthy, but all you ever do is eat an apple, and sometimes it's a red gala, and sometimes a Granny Smith. But you're not giving me any other diet, so no, this isn't healthy. And then they look at me and go, oh wow, if you put it like that, should I be doing other type of exercise? I'm like,
should I squat? Calf raise? No, I better not. I'll just foam roll. Yeah.
So it's all about, as a clinician, whatever you are, whatever background, you're a detective. And sometimes you'll be given lots of clues, which is great. But more often than not, you've got this person who's really holding on to all the clues, and you kind of have to extract them, get them out. And then the examination is kind of like homing in and confirming your suspicions. And an investigation is converting what is up until that point expert pub chat into hard objective data.
I like that. Yeah.
And then either confirming the diagnosis, grading the severity of it, helping monitor either disease progression, deterioration, or recovery. Okay, so better than one test is actually multiple tests sometimes. Say for example, fracture healing or whatever, because you've got one data point. Every investigation will add more data points, and then you can start creating a trend. Now, I talked about there being 5 to 10% of patients where at the end of the history, I'm like, I don't have a fucking clue. Well, yeah, exactly. I had that yesterday.
Would you, on that topic, how would you say that? Because I know early on in my career, I struggled. Now I don't so much, but I know younger clinicians definitely struggle just saying, listen, I don't know. And the way I generally word it is, we might not know what the diagnosis is. I'm very confident to rule out anything underlying and sinister. And what we can do is treat the pattern. If it doesn't respond, we can do this, this, and this.
No.
No,
don't do that. Don't treat the pattern. Don't treat the pattern.
If it's mechanical? I'm all ears. I've got this. This will be the tagline.
Do you know a guy called Anthony Bourdain?
Anthony Bourdain. No, I've seen that rings a bell for some reason.
Oh, well, it's because you're a young kid. That's why. Anthony Bourdain was an amazing American chef, tattooed rock star, rebel, travel cook, commentator on life. I can truthfully say I had serious man love, man crush in this guy. Sadly, he died a few years ago. He took his own life. Like the greatest people out there, they're troubled souls as well. Anyway, he, on a visit to Glasgow, my hometown, said Glaswegians don't do bullshit. And I'm telling you right now, I don't do bullshit.
Right?
I don't do bullshit. So, I will see patients, 5 to 10% of my patients, I'll be like scratching my head thinking, what the fuck is going on here? Their symptoms are atypical. I can't make head or tail of what's going on. And oftentimes people will either discount these people as crazy. Oh, that's crazy. person, oh yeah, I don't know what's wrong. I don't see anything. I don't see what the problem is. They're crazy. No. They're atypical symptoms. Not everyone presents with typical symptoms. And there's nothing wrong in admitting you don't know. And I will put my hands up and I'll say to the patient, look, I really appreciate you came to see me. And I know you've come to see me because I'm apparently the expert and you've looked me up. But I'll be honest with you. I've been doing this a long time. I don't know what this is. I don't know. This is a weird one. And I could bullshit you an answer if you want one, but I'm just plucking something out of my head and, it's a complete lie. Or I can be honest with you and say, I believe you have something wrong with you, but your symptoms are not typical and I'm not 100% sure what's going on. I'm therefore going to order tests and investigations to hopefully unmask the situation and provide us with a diagnosis. Normally, I use tests and investigations to confirm the diagnosis, grade the severity of it, blah, 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 plan treatment. But in your case, I'm holding on to that investigation to give me the diagnosis. There's even another chance that the investigation will come back negative, in which case we're in a bit of a pickle. And either what we do is we just call it quits and say, let's just sit on this for a while and see what happens. Maybe order another investigation in a few months' time to see if the problem presents itself at that point, or we get a second opinion and I send you to a colleague and we discuss your case. Or if it's really unusual, I'll take it to a multidisciplinary meeting that we have like every 2 months, and all the surgeons bring their problem cases, their weird cases together. And you know what patients, all of them say? Thanks, Mr. Malik. Really appreciate your honesty. I've had people in the past who've just bullshitted me and I can read right through them. It's really refreshing to hear someone say, I don't know.
I like it. Bullshit. Yeah, I like it.
Oh, I didn't say to you, one of the other things I say in the history and examination is, when I go, after they've given their little spiel, I say, what do you want from me?
Yeah, I do like that. I like that. Or what, what is this pain stopping you from doing?
What do you want out of this consultation? What do you want out of me? And they go, what do you mean? Sometimes they'll come off the bat, oh, well, I really want to know the diagnosis. Or, oh God, I just want to get better. I want to get back running. Some patients will turn around to me and say, what do you mean by that? And I will say, well, do you want me to give you a diagnosis? Do you want to know what you can do and what you can't do? Do you want me to make you better? What do you want from me?
I like that.
Do you want an operation? What do you want from me? And some of the patients will be like, oh, you know what? I've been through the mill. I've seen 3 specialists. I've done this. I just want an operation. And I've looked you up. People have spoken about, can you please operate on me? Like, okay, well, that's good to know. And the other people are like, oh, I really don't want an operation. And the reality is, because if you don't ask them what they want, how are you going to satisfy them? How are you going to make them happy? Because you want a happy patient. Because the key to life, my friend, is happiness.
That was really stoic if you couldn't see his face then. Yeah, I like it.
You want to be happy. You want to enjoy your job. You want to be happy with your wife, partner. You want to be happy with your kids. You want your patients to be happy. You want everybody to be fucking happy. So you need to ask them, what is it they want from you so you can make them happy? Because everybody wants to.
Yeah, I really do like that. And one thing I've started to in the last several months is, because when you ask that question, you straight away know where their motives are and kind of what they want. Because you might think, okay, this person wants to get back to running. That's what their pain stopping them from doing. But it's like, oh, I can't play with my grandkids, or I can't play with my kids. So understanding what they want from you, or what the pain stopping them from doing. Would you say it's something kind of similar to that? Because you can definitely do something that they don't even want or care about.
Exactly. You might be going off thinking, I know what's best and I'm going to do this. And they're like, they're so not interested in that. They're like, what the heck? Unless you know what their expectations are and what their desires and wants are, you won't be able to satisfy them.
Yeah.
And, it's like, I learned this stuff, off the tangent. But for example, with relationships, we've all got different languages of love. Did you know that?
Yes.
How my wife perceives me loving her is very different from me. Her language of love is service. So if I empty the dishwasher and cook her a meal, oh my God, I'm getting some. Whereas for me, her cleaning up and doing stuff, acts of service doesn't mean jack shit to me. If I wanted someone to do, I'd have a maid. I don't. Are
you a quality time man? Or what are you?
Great. I love the fact you know the language of love. I'll be honest with you. Most people have one language of love. I'm a greedy mother.
You haven't got all five, have you? You can't.
I want quality time, which is one of the reasons I took up running, so I could go running with my wife. I love quality time, and that can be doing even the mundane thing, but as long as it's in the presence of my wife. Love it. You know, not having that phone on. You know what the rule in our house is: you come home, right? You put the phone in the kitchen counter, you turn it upside down, you leave it. And you only check it just before you go to bed, any important messages, turn on the alarm, and that's it. All right. So quality time, words of affirmation. Listen, I've got seated insecurities and my imposter syndrome. And I need her to tell me I'm amazing. And then there's this physical touch, you know, just holding my hand, stroking my neck. Oh, I love it.
Yeah, I'm the same on the physical touch. Watching TV and things like that. If you're on the other side of the lounge, it's not happening. It's not happening.
Yeah.
It's something. It's gonna be, even if it's a foot touching, it's gotta be something. It's good.
100%. Yeah, 100%. But the thing is, like, you know, if we don't know each other's language of love, you know, you could be giving all the love in the world,
and you think
and I won't be loved. You know, it was early on in our relationship. My wife was like, right, she'd come home and just like busy cleaning up everything and tidying up. And I'm sitting in the corner thinking, I don't feel loved. Is it what the fuck? And she
touch me. Yeah.
Yeah, but because that's her language of love, so that's another mistake people make. Because that's her language of love, she thinks what I want is the same. And that's coming back to her history taking and her expectations. You might think, right, I'm going to do this for the patient because that's what I would want, and I'm going to make them. And the patient's looking at you going, good for you, but that's not what I want.
Yeah, and
so,
I
figuring
agree.
out right from the beginning, what does your patient want? Because don't assume anything, because everybody wants different things.
Yeah, I like it. All right, well, let's get to the crux of it. There's some really cracker questions. Now, I've sent these through prior, and I was having a look at these, and after I sent them through, I really started to think about it, because one of the students asked me opinion on a case of her daughter, and she gave me a couple sentences, and I was like, it's really hard for me to make any kind of comment at all. I don't have a history, an assessment, or anything. So when I had a look at these questions, I was like, this is really subject specific, but I mean, have your best crack at that. So I've got here, what's your opinion on non-operative Achilles and operative Achilles for an active person? And we'll just use the example of someone that plays sport, recreational, touch footy, soccer, and someone that, you know, just wants to walk here and there.
Yeah, so I mean, basically, so non-operative management is really a good option, and in some cases a better option for a lot of people, right? So if it was my Achilles tendon rupture, if I got it picked up quickly, I had an ultrasound scan, in equinus, I've got a gap of less than 10 millimeters, I'd get it into a vacoped boot, you know, not an air cast with wedges, an actual hinged boot. And I'd start early functional rehab. Okay. Yeah. Would I want a trainee surgeon doing an open Achilles tendon repair in the Nash, you know, at 8 o'clock at night with no consultant supervision, cobbling together my fucking tendon, getting it infected? No fucking way. Right? No. But if I've got a gap of 20 millimeters, the next scan shows there's even more retraction.
Is that the gap between the rupture, or between
the two ends of the tendon?
Yeah,
the gap is big. And when I do non-operative management, I like to do weekly ultrasound scans to make sure that the tendon gap isn't increasing. Does that make sense?
Yeah.
And I don't want that. I don't want the tendon gap increasing. Now, if, for example, the gap starts to increase, or it is big to start off with, I want an operation. I want an operation. And if it was someone like me, who is a specialist and knows what they're doing, then I want an operation, because it'll be a small incision, it'll be percutaneous, I'll be able to move my foot and ankle straight away, confidently. I'll be able to activate my calf complex. So I'm going to minimize muscle wastage. I'm going to start weight bearing within 2 weeks and be out of a boot within like 4 or 5 weeks, and hopefully return to sport in 4 or 5 months.
Yeah, wow, that's quick.
Yeah. really quick, and not worry about re-rupture, blah, blah, blah. So it's all relative, you know, who's doing it, what are the circumstances. It's so nuanced. So, you know, half my patients I treat non-operatively, and half my patients I operate on. And if someone is like, and I'll offer my patient, I will give my patient the choices. I won't make the decision. I'll say, look, these are the pros and cons of each option. You know, what do you want? And there'll be some people who will be like, oh, I really don't want an operation. You know, you tell me the gap is looking good. I'm like, yeah, great. So I can start early weight bearing and functional rehab. Yes, we just have to go a little bit careful. Have lots of ultrasound scans to make sure it's all knitting together and you're not over lengthening.
So it knits back together. Is that right?
Yeah.
Oh, wow, that's awesome.
Yeah. So the clot will mature, get replaced with fibrous tissue, and then you'll get tendon, you know, reforming.
Yeah.
And what you don't want is it to heal over lengthened, because then you have no propulsion. Just imagine you've got a bit of tension on a rope and you put slack into it. Doesn't matter how hard you pull, if there's slack in that rope, you're not going to achieve any movement on the other end. You need a bit of tension. So if it's over lengthened, your calf will just disappear. You won't have any propulsion. You won't have any push-off strength. So you want to avoid over lengthening. Now that comes back to you know, therapists quite often, you know, they use range of motion as an outcome measure, right? This is limited movement. That's what normal movement is on the contralateral side. I'm going to get full movement. No.
Yes, that's good. Yeah.
It's not a race. Because if you try and over lengthen, achieve full range of motion, particularly in dorsiflexion, all you're going to do is over lengthen the Achilles, and then they've got no power. Their muscle will never, you know, reverse the wastage, and then you're in trouble.
Yeah. So more capacity building, like strength. Obviously, strength and conditioning is usually I would say probably the most evidence-based therapy out of all musculoskeletal conditions, but 100%. More focusing on the capacity rather than range of motion, massage, needling, all that kind of stuff, you know, to try and get that extra centimeter, which it's just arbitrary, really. Like, what do you need that for?
Yeah. So a lot of my patients at week 1 will start TheraBand exercises, so isometric or going into plantar flexion.
Yeah.
So they'll be doing movements in plantar flexion and going up to end range at dorsiflexion, so wherever their foot wants to get to. But they're not forcing it. And then in the boot, they're slowly going down from 30 degrees Aquinas to 25. Every 4 or 5 days, they drop it. And then, you know, into a shoe with a heel to toe drop of 5 millimeters. But they're trying to just avoid that over dorsiflexion because it just stretches you out. And a lot of it is just the strength building, you know, resistance work on that calf complex and lower limb muscles.
So it's more, anyway, by the sounds of it, it sounds more related to, which I assumed it would be, it's the presentation rather than you're more likely to enjoy sport and you're less likely to re-rupture if you have it, if you have surgery. Rather, it's really how it presents and the gap between, you know, the rupture and the Achilles tendon.
It's everything. It's, you know, what the patient wants as well. So, you know, I'll have a patient who wants to get back to, you know, county cricket or whatever. They need to get training or, you know, all this kind of stuff. So they want to rehab faster. They just want to get going. Then there'll be other patients who are like, oh, you know what, I'm quite happy. There's no rush. I just want to get back. You know, if you're telling me I can have non-operative management, let's do it. And they do really well. But, you know, if someone's been walking on their foot with a rupture for 2 weeks, they've got a gap of 4 centimeters, you know, I'll be getting off the fence and saying you need an operation.
Yeah.
You know?
Yeah. And which leads me to, I wanted to ask a question. I was thinking about this during the week and similar kind of presentation, but in the forefoot, because I think from a podiatrist standpoint, and probably not strictly podiatry, but podiatrists definitely treat a lot of those fiddly forefoot, bursitis, neuromas, capsulitis, plantar plate, and that kind of thing. You know, what would be the most common, I guess, presentation you would see for a forefoot or get referred for? Is it neuromas? Is it capsulitis?
So I think by the time people come to see me with forefoot stuff, it's mainly bunions or arthritis of the big toe. I see people with lesser toe deformities. I've just done something, a Butler's deformity. It's when you've got hyperextension clawing of the fifth toe. It's a kind of congenital problem. I did that recently. Morton's neuroma, I can't remember the last time I cut one out. I don't even inject them, to be honest. I offer them one injection under ultrasound guidance. I don't want to be the one injecting them. Plantar plate, I've seen one recently. Again, I'm taping him. There's evidence to show if you tape them up 3 months.
Yeah, with the plantar flexor. And like that's plantar flexor taping, even a met dome, and maybe a rocket shoe generally works pretty well.
All of that. Absolutely. You know, a lot of these will end up healing and recover. So, you know, look, Morton's neuroma, I'm always thinking, what's caused this? You know, what's caused irritation to this nerve? And I think it's hilarious that anywhere else in the body where there's irritation of the nerve, where would you cut the nerve at? You know, why would you do that? You wouldn't cut the nerve at. You know?
Yeah.
So I don't really like cutting the nerve at. I just, no thanks. You know, I always think, well, what is going on? I mean, like 90% of people that I see are wearing shoes far too tight, too small. You know, if you're a forefoot runner and you know, your nails are falling off and your training shoes, your toe, big toe and little toe are right up against the shoe. I mean, that's a no-brainer. You know, adjust your footwear. Get an orthotic in there if need be. If you've got tight calf muscles, reduce that because that increases forefoot loading. If you're, you know, a forefoot runner, maybe transition to mid to or heel strike. You know, whatever. Just, you know, a steroid shot is not a benign intervention. The number of complications I've seen from steroid shots, from tendon ruptures, plantar plate ruptures, toe dislocations, you know, fat pad atrophy, really horrendous fat pad atrophy. You know, it goes on and on and on. You know, these are not benign interventions.
Yeah, it's a bit of a. I explain it to patients like a spectrum of one side. You know, this is chopping off your foot, and here's doing nothing. You know, we follow things in a nice logical order. You know, footwear, orthotics, offloading, modification. You know, steroid injections are down this end near surgery, so we don't jump all the way over to there and then go backwards. What do you for bunions? Because I know, do you do? Now, I'm sure I'm going to butcher it. I know there's keyhole, and is it not a colectomy? There's something that a keeler procedure. What do you do for bunion surgery?
So it depends. So bunions are like a fruit basket. Okay, you got blueberries and you got watermelons. You know, you can't just put them all down as, you know, just one thing. And there's not even apples and pears. It's a proper fruit basket. It's interesting. This year at the British Orthopedic Foot and Ankle Society meeting, there's a paper presented that showed that the size of your bunion has no relation to your symptoms. People have, I've seen patients with massive bunions. You know,
I agree. I would agree with that.
Yeah. In their late 70s, horrendous. And they're like, oh, I've had this for years, doc. It's okay. You know, it doesn't bother me. I'm here about something else. I'm like, okay, wow. And then you've got, you know, people who've got the smallest bump and are crying with pain. You know, so, you know, it's funny. It's funny that. So, but also pain is so subjective and so very, really still, you know, confuses me. Pain is just something I just don't understand. It's a murky world.
Very complex.
Yeah. But for mild bunions and, you know, I would do something called a scarf and Aiken osteotomy. So it's a distal osteotomy. It's not minimally invasive, but it's a small incision. It's a mini incision. It's not very big. Where there's a massive deformity, a very big IM angle, where there's hypermobility at the TMT joint, I think nothing beats a lapidus, which is fusing.
That's the one. Sorry, that's what I was thinking.
It's a beautiful operation. It's such a good operation. Sometimes I get caught out. I think, I'll do a scarf and Aiken. I'll get a great correction, and a year later the bunion's back, and somehow I didn't pick up, or it wasn't obvious that they had first TMT joint instability. And because if you imagine, you know, the leaning trapeza, you know, the leaning trapeza. You know, if you're correcting the tower at the top, breaking the, you know, the top 3 floors and shifting it across, you're not really addressing the problem, which is at the bottom.
I like that for like hypermobile midfoot patient, and you might be talking about trying to stabilize their forefoot. I like that analogy.
You need to correct the base. You need to fix the base. You know, doing something at the top end, okay, you might get the top floor over the base, but it looks fucking weird. It's not right.
It's not going to stay there.
And it might carry on. It might carry on going. If you want to really fix that, you need to straighten up the whole building. And that's then at the bottom. That's at the TMT joint, you know. Yeah.
Do you think, I mean, and it's always hard because the number one question I tend to get, you know, sometimes when they're painful, sometimes when they're not painful is, you know, what's caused this? generally, and please correct me if I'm wrong, and I hope I don't have to say the wrong thing, I say that we don't really have a great idea. We think there's definitely a genetic component to the development of bunions, and as well there's an environmental component, whether that be footwear or what environment the shoes have been in. Now, this is what I've been adding in the last 6 months, is I have read a paper that they hypothesize that there may be an increased risk in hypermobility. Is that wrong? Have you heard that?
No. I mean, the funny thing is hypermobility is a big thing, but it's not the majority of my bunions.
Yeah, okay.
I would probably say it's around about 5-10% of the bunions I see.
Okay.
And you're right, we don't really know why people get bunions. I mean, there's definitely a genetic component. The number of patients that say, oh, my mom's got this, my aunt's got this. Yeah. Very, very common. So there's a genetic component to it. And then, I mean, there are conditions like rheumatoid arthritis and inflammatory conditions that can cause it as well. There's also the chicken and egg situation. You know, if you develop an acquired flat foot, it will cause a bunion. But a bunion will also cause your arch to collapse.
So yeah, which one is it?
I know your viewers can't see this, but let me just demonstrate on this table.
Yeah. No, well, I'm recording the video as well, so I'll put this on the Instagram.
You know, if this is left foot, right foot, and you know, and that's the heel bone, and that's the big toe, that's the little toe. You know, if you develop a bunion, look what's happening to the arch. Yeah, the arch is going to collapse in. But equally, if the arch collapses, it will force your big toe into valgus, and you get a bunion as well. Yeah. So it's very important to always ask the patients, you know, what came first? Did you develop a bunion first and then your arch started to drop? Or did your arch drop and then you could? And, you know, I've got a patient like this and he's not really sure which, but the reality is he's got hypermobility in his first TMT joint. What I'm going to do is give him a lapidus. He needs a lapidus. Even though the bunion isn't massive, it's a moderate bunion, and I could do a scarf and Aiken. I think he's got hypermobility, instability in that medial column. I need to fuse it. That on its own might be enough to address the arch, but his hind foot's also going into valgus because he's got an Achilles contracture. You know, his calf completely tight. So I'm going to do some form of gastroc lengthening. So I'll do a gastroc lengthening. I'll do a lapidus. I'll then see what he's like on the table. If I'm still not 100%, I might then put a sinus tarsite implant in just to.
Oh, yeah, I've seen those. Yeah, that fall open.
Heel and neutral. I won't do the full shabam, calc, osteotomy, FDL tendon transfer. That's not his pathology. He's not got any disease in the medial ankle. Yeah. But his hind foot does need to be neutral, and his Achilles needs to be lengthened, and his medial column needs to be stabilized. So see how it's a little bit more complicated bunion than just doing a scarf and Aiken osteotomy. And if I did a scarf and Aiken osteotomy on him, his flat-footedness will not improve. It'll only get worse, and he will get a recurrent bunion.
And he's just coming back in. Sorry, you go.
No. Okay.
On that topic, talking about if you didn't do that, you know, it's quite possible that he would have, you know, ongoing issues. Is there a role for custom orthotics in that kind of presentation with that kind of midfoot and TMJ?
Okay, fantastic. Guess what the outcome for this patient is?
What?
So I offered non-operative and operative treatment.
Yeah.
And the pros and cons. And he said, what do you recommend? And I said, well, I don't like to recommend to my patients. I like patients to just come to their own conclusion, because if they're asking me that question, they haven't done the research, they haven't read the information I've sent, and you know, it tells me that you're not able to make an informed decision. So I need to go back to informing you. And he went, no, I know, but just, you know, and they really push you. If it's your wife, I said, look, the safe option is, I think the fact that you're asking me this tells me that you're not ready for surgery. And he started nodding, and I was like, I can sense that you're not keen on surgery. He went, I'm not. I went, well, it's very simple then. We're going to do non-operative management. You're going to see a physio for stretching out your calf muscles. You're going to see a podiatrist for custom orthotics to, you know, hold your heel in neutral and support your medial arch. You're going to wear wider fitting shoes with a deep toe box to accommodate your bunion. And we're going to see you again in 6 months' time with another set of x-rays We're going to see if your bunions progress. We're going to see if your flat-footedness has got worse. We're going to see what your symptoms are like and whether you're tolerating non-operative management. And if you are, you carry on, and maybe I'll just see you every couple of years. And if you're not, and it's not working, and you're still in pain, and there's deterioration on the X-rays, we can think about surgery. And the fact that we've done this, and I know that we've tried everything to avoid an operation. And if we come to the conclusion that surgery is required, it's because it was required. Because I like that plan. Let's do that. So that's what we've done.
Yeah. God, that podiatrist will be sending you a Christmas present this year. We joke about it on the podcast all the time. It's gotten to the point. Yeah, it's common in every profession.
I don't get anything from anyone. Honestly, I don't. I swear to God, I don't.
Yeah. Do you think, like, obviously foot and ankle things, and we always I guess the crux of what our profession as in podiatrists tend to give other professions problems in the sense that we overprescribe custom orthotics. Yourself having a pretty in-depth understanding of biomechanics and foot and ankle movement and things like that, do you tend to gravitate towards, customs versus prefab orthotics, like the ones that are already made and you modify them? Or do you think?
So I have recently, about 9 months ago, started offering orthotics. So I'm using the gait motion technology, dynamic foot plate, and I'm using FITS, PHITS orthotics, custom, not for everyone. And the way I also do it is, I think, non-operative treatment is this orthotic. I can provide it for you. Here's the literature information. Here's the cost. Or you can shop around and go see another podiatrist, and they can provide, as long as it's this is what you need. Why am I doing this? Because I've been let down by a lot of people.
Yes, and that's common. It's a common thing. And
I just want to make it clear, not just podiatrists. I get let down by fucking everyone. I set a very high bar on myself. Like, I'm really critical of myself. I want to do better, but equally, I set a high bar on everyone else too. And I've been really disappointed by a lot of podiatrists who haven't provided people with what I've asked. Someone with severe arthritis in their big toe, they need an orthotic with a Morton's extension. The patient comes back after 2 years, and I go, "Oh yeah, did the orthotic help?" And the guy goes, "It was made no difference." I'm like, "Really? Let me have a look." There's no Morton's extension.
Yeah, because it's like the crux of doing an extension is it reduces the force. It can't not make a difference if you're getting pain in the big toe because you're reducing that moment.
And I'm like, what the heck? And like, yeah. And it was really expensive. It was £1,000. And I'm like, it didn't make it. I'm like, £1,000?
Yeah.
And the number one thing I hear is, oh yeah, they told me that it has to be made in Canada, or it was made in Australia, or it was made in America. Yeah. Like, the further away it was made,
this one was on the moon, so it's £2,000.
Yeah. This was a special one that got shipped all halfway around the world. Like, don't give me this fucking shit, right? Yeah. I know it costs you £80 to £100. Your markup is fucking horrendous, and you're taking this guy for a ride. Don't give me this shit. But equally, look, I want to make it very clear to your listeners, I'm not having a go at podiatrist. I fucking everyone. I sent a patient to a bone tumor surgeon because I thought there's something weird going on here. I think it's a simple bone cyst with a stress fracture, but it might be. There's a 1% chance it might be something more sinister. I'm going to send it to a bone tumor surgeon who will discuss it in an MDT, and they'll let me. This guy, he's already on his second life, right? Because he's let me down already. So, I always give people more than one chance.
Yeah.
And, 3 weeks, didn't hear anything. The patient went to see him. He said he didn't have any of our letters. He didn't have the scans. He didn't do his prep work. He was running late from surgery. He was rushing the consultation. Patients paid a lot of money, and the guy just wasted her time. Didn't give me any letters. Patient and I were both hounding him for an answer. And 4 weeks later, we finally get, oh yeah, it's a simple bone cyst, and it was just a stress fracture. But the whole time, this patient who's already had melanoma is freaked out by cancer. She's stressing out. She's saying he's rude. Even his secretary badmouths him. Blah blah blah. And you're just thinking, this reflects badly on me. Because I referred this patient to him.
Yeah, it's on you. Yeah,
it's on me. And now I'm having to look. Now that's it. 3 lives, you're out. Boom. 3 X's, you're out now. And full on me. Maybe I should be like, once you let me down and never again, but I always try to give people the benefit of the doubt.
Yeah.
So, it's not just pods or physios, it's surgeons, it's colleagues. I had this anesthetist who, pitched up late, and, he was a fill-in for one of because my anesthetist had COVID and couldn't come. So I got this other anesthetist to help out. And on the day, he canceled 2 of the operations because, oh my God, this patient's on hypertensive medication, and they're on inhalers, and I think they need a cardiac echo, and I think I was like, why? Oh no, it's not safe. This patient's really unwell, and the patient's fucking fit and healthy. And he's atopic anesthetist. I ended up canceling 2 of my patients. I sent them to the cardiologist, and the cardiologist literally stopped me in the corridor and went, "Why the hell did you send me those patients? They're perfectly fine."
The
anesthetist said, like, the ECG tracings were wrong, and he was like, "Are you kidding me? They're all fucking healthy as anything." And this anesthetist totally messed around my patients and me. Do you think I'm ever going to use them again?
No. And it's common, and it happens to, I feel like every health professional has had that experience, and it makes it quite difficult because you want to work with them and you want to get outcomes together. But if you refer to them, I know an example, and I'll talk about myself here for a little bit, where we work with a lot of physios, chiros, osteos, massage therapists. And I think I'd like to think it's because we're really good, but probably not. It's just because we seem to be sensible. Like if somebody comes in with forefoot pain and they've only had it for a couple of weeks, it's not always an indication, great, you need this $600 custom orthotic. Maybe we might do, a prefab, which is about $100 with a little bit of a wedge on the outside. Generally, they can get better. And I don't think a custom as specific where you can argue that it has to be custom or it's not going to work. Just sensible and logical compared to if someone's got an adult acquired flat foot, that's probably more like they might need a custom 100%. With a skive or a big flare. So I'm happy to hear you say that.
100%. So I had a patient recently who came to me and said, "Oh yeah, can you make me an orthotic?" And I looked at her foot. I was like, "You don't need an orthotic. What you need is more sensible shoes. Go to this company and they'll help you out. Just because I can offer them doesn't mean I should." And it's whether it's an orthotic or injection or surgery. Now, we were almost out of time. You sent me some very important questions.
Yes. Let's get into them. I knew we were going to talk about that.
Yeah, because
you go through them.
Let me quickly go through it. You said to me, like, what could our profession do better? What could, young referrers and when to refer, all that kind of stuff. Right. Like, I think it's better to refer early because, don't treat patterns, don't treat symptoms. I get that quite a lot. And whether it's doctors or physios or pods, people hate to admit they don't know, hate to say they don't know what the diagnosis is. They'll give a bullshit answer or they'll treat symptoms. Patient goes on and on, getting the same exercises, definition of insanity to keep doing the same thing, hoping for a different outcome, and they're not getting anywhere. As a clinician, my role, my first primary role is to diagnose the patient. And you know what, having been a patient, I can tell you right now, just knowing what the fuck is going on is half the battle. Just knowing, okay, that's what it is. Next, what can I do and what can I not do? Oh my God, that's so useful to know. Okay, so running isn't going to make it worse. Great, I'll run. Oh, so I should rest it. Okay, how long should I rest it? So getting the diagnosis provides you with a prognosis, provides you with information, facts, details, planning your therapy. Okay, so get a diagnosis early. And if you're not sure, find a good clinician, a good surgeon, and don't think that they're just going to operate on anyone. And make it clear in your referral and get to know them, meet them, phone them, visit their clinic and say, look, what I want from you, my primary ask is help me get a diagnosis, help me with diagnostics, help me with this, help me with patient management. I'm not looking for a gung-ho surgeon who knife
I like it. Yeah.
Make it clear and build that relationship. And if they let you down, call them. Fucking chop them out of your lives. Move on. Find someone else. And also the ones that are smooth talking, talk the talk, out presenting, podiums, research. Half the time they can't fucking walk the walk. They can't operate. They cannot operate. People who are good surgeons are just doing their craft. They're just getting on with it. Okay, it's like everything in life, every walk of life. But build those relationships. Get off your ass. Meet them. And if you think, oh no, but I'm just a look. No, you're not. You're never just anything. You're a clinician. You care about your patients. Have some self-worth. Just because they're a doctor or surgeon doesn't mean they're God. And if you think that they're God, well, it's your fault for putting them up there, and that's why they're going to have those egos. And if you meet them and they have got an ego and they do think they're God, well, fuck them and just get them out of your lives and find someone who's good.
Right, I like it. I feel I'm pumped up at the moment. It's good. This is really, really good.
Right. Just, you know what? Seriously, if the doctor's an arrogant wanker, sorry, but the narcissistic weird, just get rid of them.
Yeah.
You got the power. Just don't work with them. Find someone on the level. Find someone who's humble, who's got humility, who cares about their patient, who's in sync with you, who thinks like you. Do it. Don't undersell yourself.
Yeah.
Work like a team. And guess what? Your patients will love you. When you say to them, you know, I'm going to phone my surgeon. I'm just going to pick their brains. I'm going to see whether this is worth a referral or not. I'll let you know what to say. I get this all the time. I've got physios like literally halfway around the country who would never refer to me, never. But they'll message me on WhatsApp and say, hey, Ahmed, how you doing, buddy? You know, I meet them from Instagram. I've got this patient, I've got this kid, blah, blah. What do you think I should do? And I'll tell them. I'll say like, yeah, send them to your local surgeon. Like, oh, thanks, Ahmed. Cheers a bunch. There you go.
Yeah, easy as. Yeah.
Have a nice relationship with people. Now, next, where do we go? I hate it when people hold on to patients.
Yes. Yeah. We harp on this on the podcast. We do. Like, if things aren't getting better, they're not going to continue. You know, it's been 6 months. It's probably not.
No, but not even that. Not even that. Not even that. Things are getting better. Things are getting better. Fucking let go of them. You know, if you're a physio and you're rehabbing someone post-op, you know what? Say, I think you're ready for a strength and condition coach. I think you're ready for a running coach. I think you're ready for a personal trainer now. You know, I hate it when the physio turns around to me and goes, but I can do personal training. No, I can do the rank. I can do the ultrasound scan. I can do the shockwave. I can do the orthotics. You can fucking do everything, can't you? Well, you might as well do the operation.
Do the surgery as well. Yeah.
You just fucking do everything. I mean, what the fuck? You know, experts are experts for a reason. Don't be a jack of all trades. Work with your colleagues. And, you know, I hate the hierarchy of clinical arrogance and superiority. You know, surgeons think they're superior to doctors. Doctors think they're superior to nurses. Nurses think they're superior to physios. Physios think they're superior to pods. Pods think they're superior to sports therapists. Sports therapists think they're superior to chiropractors. Chiropractors think they're better than massage therapists. You know, it goes on and on.
Yeah.
Fucking hell. Oh my God. You know, I work with some pretty amazing personal trainers, and I can tell you, they turn around to me and say, look, actually, you know, I thought the surgeons would be the ones treating me like shit. It's the physios. They look down at us.
It's that ego barrier, isn't it? Yeah.
What the fuck? The ego barrier, you know. So don't give me this thing. It's like saying, you know, the white guy is a racist when the black guy is racist to the Chinese people. You know, we're all fucking racist. You know, racism isn't just between one type to another. You know, all races are racist or potentially racist. Yeah. And all therapists are potentially arrogant and ego-driven. Ego-driven. So put your fucking ego aside. Put aside your, you know, desire to have money and, you know, rape the patient with as many consultations as possible, and think, no, what is in my patient's best interest? How can I help my patient? How can I get everyone around me with their and tap into their knowledge and expertise? Because I can't know everything. And someone else will know something better than me, and I'm going to work with them. And you know, when you work with this win-win mentality and put your ego aside, you will thrive. People know you're looking out for them. Patients will love you. They'll send more patients to you. Other clinicians will love you, and you will become so good at what you do. It won't happen overnight. It won't happen overnight, but it will happen. It will fucking happen. But if you're like, no, I'm going to hold on. I'm not fucking sharing. I'm possessive. It's all about me. I'm going to be everything. What the fuck? I'm better than them. Well, I ain't working with you. Yeah. And sooner or later, people are going to find you out.
Yeah. And you can't be everything to everyone, for sure.
Yeah. It's a horrible, lonely existence. So don't be arrogant. Don't have ego. Don't think you're better than anyone else. Because if you feel upset that the surgeon is being a wanker to you and treating you like shit, well, equally, you don't treat other people like that. Okay? Don't pass it on. Yeah. And the last thing I would say is communicate. Now, you asked about letters and correspondence.
Like, because it's a common question and people get taught different things. Universities
I'll be very quick. Look, everyone's busy. No one's got time to sit down and put down a detailed letter and print it off on quality paper and put it in a stamp on it and post it. You know, times are changing. You know, with the patient's permission, say, look, can I correspond with your clinician, your surgeon, whatever? Are you happy for me to email? Do you want it encrypted, unencrypted? Are you happy for me to WhatsApp? Do you want me to include you in the group? Can we do this? Can we just do one-liners? Can I pick up the phone and speak to them? Anything. The best relationships I have are with physios and pods who literally will just WhatsApp me and go, hi, saw your patient AM today, blah, blah, blah. They're doing really, really well. Just checking with you. Is it okay if I can do this? One-liner back. Yeah, amazing. Yes, you can. Yeah. Oh, don't do that for another 3 weeks. That's it. And they will think that little question doesn't warrant a letter, and it doesn't. And most people will not bother communicating and will just go with the fly and make up their own shit. But the good clinicians will be constantly communicating, and I'll be like saying, can you do this? And they'll be saying, can you do that? And I'll be asking them questions. Is this okay? They'll send me information back. And this information, communication is vital. And anything is better than nothing. Yeah. And honestly, 90% of people I refer to, it's a desert. It's just a dust bowl silence,
Yeah, I know what you mean. Yeah, you don't know what's happening. They're your patients. You've just done operations or non-operative. Like, you want to know what's going on. Yeah.
And quite oftentimes I'll discharge patients early because, like, at the end of the day, I don't want to be. Again, I live by my own motto. I don't want to be bringing people back unnecessarily for appointments. I know at 3 months, at 6 months, this patient's going to be doing really well. But at 3 months, they're not healed. But at 6 months, I don't want to see them just for them to tell me, hey, I'm doing really well. So I'm relying on their therapist to be saying hey, by the way, just to let you know, patient's doing really well now. I've discharged them as well. And what they don't know is I'm keeping tabs of all my patients. I'm fucking messaging them anyway. So I'll ask my patients at 6 months, how you doing? Oh, really well. I was discharged a month ago. I'm like, oh, thanks, physio or whatever, for letting me know. At first, I'm hearing of this. Or I'll be like, the patient will be like, yeah, I've got some pain. They've recommended another 10 exercises. I'm like, all right, well, is it making you do it? I don't know. I spend half the time just chatting about their extension. I don't know if I'm really getting anywhere. I'm like, what the fuck? Get in my clinic. Let's find out what's going on.
Yeah. That's important. That's really important.
Communication is important. Is that okay? I hope this was helpful.
Yeah, mate, that was great. I'm really excited to really can. I think one thing I did want to add just to finish, I wanted to ask you, for students, clinicians out there, how can they find you at London Foot and Ankle Surgeon on Instagram? You post some incredible content. You've got like 4,000 followers. You're basically an influencer at the moment.
I'm not an
And
I don't think that's very much. All the people I'm following are like millions. I've never done it for followers. I've never done it for followers. I just want to get myself out there and share the love.
Because your content's digestible. When I say digestible, in the sense of you can read it and then I can implement it clinically, or I've got an understanding when patients ask me. You've got this cracking post about the moon boot and the heel lift and how it looks on X-ray. It's awesome. Like, you just don't learn that unless someone like yourself is putting that content out there. So at London Foot and Ankle Surgeon, and then get a follow and build up your profile. But you'll be able to retire soon and just start doing sponsorships.
So actually, I'm going to start a podcast, Doc Malik, Honest Health.
Yeah.
I'm putting everything together. It's going to probably go live in 3-4 months, and it's going to have everything on it, from health, nutrition, wellness, mental health, exercise, where we source our food from, clean water. It's going to be everything. It's going to be everything.
Make sure you send me a message, because we'll have to share it around through here. I mean, we'll see how the Australians take it, but I'm sure they'll take it well.
Well, I don't know. You Australians might not like me because of my stance on COVID and everything. You guys have kind of gone crazy.
I
will make it clear to all your listeners. I am one of those horrible anti-vaxxers. Someone who's been vaccinated over 20 times in his life does not like the COVID vaccine.
But you've got good reason. It's not this the general no reason or evidence to back it up. I'll give you that.
It's the opposite. It's the evidence is that it's experimental, that there's a serious adverse effects, and we don't have safety data. And I'm now at a stage in my life where I'm thinking about everything that I pass through my lips, where I get my water from, where I get my food from. Is it genetically modified? Does it have pesticides? Is it organic? Is it healthy? Is it pasture fed? Is it local? Seasonal food? And I'm meant to just take this genetic therapy that's just out of some bench lab with no long-term data and just stick it in me. which now doesn't stop transmission, doesn't stop infection, doesn't actually stop hospitalization. You need a booster every 6 months. I mean, what vaccine have you ever heard of like this?
Yeah,
you know,
none.
You know, where? And to justify all the lockdowns and draconian measures, no.
I did read somewhere that orthotics help, don't they? Custom orthotics.
Oh,
and you've got to get 4 pairs for all your shoes.
Has to be custom, and you need ones every 3 months.
Yeah, and I'll look after that for you.
All right, guy.
All right, lovely, mate. Lovely to have you on.